Health psychology is a branch of psychology that focuses on how mental, emotional, and social factors affect a person's physical well-being. This field is also sometimes referred to as medical psychology, since it focuses on a patient's mental and emotional relation to an illness or the recovery from an illness. Health psychology focuses on promoting health, preventing and treating diseases. It also focuses on understanding how people react, cope, and recover from an illness. It also focuses on improving the health care system and the approaches to health care policy. Health psychologists look at psychological factors within a biopsychosocial model to uncover what influences health choices in relation to biological, psychological, and social factors. Current issues in health psychology are stress management and reduction, weight management, improving recoveries, and teaching coping skills, as well as smoking and smoking cessation, which is the topic of this presentation. Smoking is harmful, and statistics show that a lot of smokers die every moment. Yet tobacco companies go on victimizing smokers. People should be aware not to become replacement smokers. According to Perkins 2010, many factors influence tobacco dependence at the onset, maintenance, and cessation levels. Such factors include genetic, environmental, personal, and traits, personality factors, as well as the effects of pharmacological and non-pharmacological components of cigarette smoking. In general, it seems that the pharmacological and behavioral processes that determine tobacco addiction are similar to those that determine addiction to other drugs, such as heroin and cocaine, since most new research is focused on the fact that nicotine affects dopamine, which is a medication form of a substance that occurs in the human body. Tobacco as a plant which carries in its leaves an alkaloid called nicotine, responsible not only for several pathophysiological changes in the body, but also develops tolerance to its own effect. Studies suggest that the alpha-4 beta-2 nicotine acetylcholine receptor subtype is the main receptor that mediates nicotine dependence to facilitate neurotransmitter release, producing mood pleasure. Repeated exposure to nicotine develops neuroadaptation of the receptors, resulting in tolerance to many of the effects. Geloha 2010 explained how stoppage of tobacco use leads to dysphoria and hedonic dysregulation, that pharmacotherapies work by blocking the reinforcing effects obtained from smoking without causing excessive adverse effects. Nicotine dependence reflects the use of nicotine physiologically needing to use increased amounts of nicotine to achieve its desired effect to satisfy addiction. Nicotine discontinuation of tobacco use produces symptoms such as craving for nicotine, irritability, anger, anxiety, depression, increased appetite, and continuous use despite significant problems related to tobacco use such as other health problems. Smith and Fuhr, 1999, stated that nicotine-dependent tobacco users also appear to be at increased risk for psychiatric conditions and other addictions, such as major depression and alcoholism. According to Binovitz, 2009, nicotine sustains tobacco addiction by binding to nicotinic cholinergic receptors. Thus, it facilitates neurotransmitter release and mediates the actions of nicotine in tobacco victims. Nicotine dependence development is activated through dopamine, glutamate, and gamma aminobutyric acid release. Binovitz also maintained that nicotine dependence is also heritable since genetic studies indicate that nicotine receptor subtypes and genes play a role in the development of its dependence. Physiological factors constitute the basis for addiction, while behavioral or learning factors sustain it. Environment stimuli are associated with the positive reinforcing effects of nicotine that over time such stimuli begin to control behavior through exposure to associative learning that cravings get evoked. Hatsukami, Steed and Gopka, 2008, listed some stimuli to include smoking cues such as smelling tobacco, smoke, or seeing other smokers, an ashtray, lighter, etc. Or situational cues, which include frequenting bars where alcohol use usually comes side by side with tobacco smoking. This associative learning is considered to contribute to nicotine addiction and vice versa. Nicotine is also observed to enhance such stimuli effects and reinforcers. Kane, 2014, stated that most start smoking in their teens, especially if parents smoke. Teenagers think they feel cool smoking with friends and taking part in other risky behaviors. Smoking is a biological addiction, but there is more to being hooked on cigarettes than the physical addiction. Smoking addiction is influenced by emulating the behavior of others and trying smoking until it becomes a routine, thinking that it helps to cope with stresses, for example. Culturally, smoking is influenced by glamour and exposure to depictions of smoking in movies, as well as advertising that promotes smoking. There are many psychological and social pressures on smokers, both beginners and quitters, and only understanding of the bad habit is the first step in overcoming these pressures with the right strategies. Behavioral approaches to smoking cessation enhance smokers to change their behavior, considering how individuals perceive these approaches, since behavioral interventions focus on the environment and the individual's thoughts on the basis of social learning, as stated in Slama 2000. A theory which stems from the observation that behavioral change is normally difficult. and that the environment influences lifestyle choices and vice versa. Igbo and Brown 2015 stated that smoking causes over $500 billion dollars in socio-economic damage every year. It is evident that smoking impacts society and economy, hence the need for cost-effective smoking cessation measures. Smoking restrictions in workplaces, public places, bans on tobacco advertisement, and raising the legal age of smokers. It produces potential economic benefits from the production and consumption of tobacco, huge tax revenues, as well as employment in the tobacco industry. Yet about 15% of healthcare expenditure in high-income countries can be attributed to smoking. Balancing probabilities, cessation measures proved effective and cost-effective to individuals and primary health care providers. Yarvik and Hinnenfeld, 1988, reviewed pharmacologically based approaches for the treatment of tobacco dependence. Pharmacologic treatment approaches consider that tobacco dependence is mediated by the actions of tobacco-delivered nicotine to the central nervous system, reinforcing nicotine effects in the alleviation of anxiety and control of weight, as well as neurohormonal regulations which become important to the maintenance of emotional well-being and performance. Biobehavioral mechanisms and pharmacologic intervention should be able to assist in initial tobacco detoxification and help tobacco abstinent persons to avoid subsequent relapse by nicotine replacement, for example, in which dependence is transferred to a safer and more therapeutically manageable nicotine delivering formulation. Manufacturing a safer cigarette would likely have both positive and negative implications for a nation's health, since removing toxins may reduce the incidence of smoking-related diseases, while smokers might be less inclined to quit since those who have quit might resume the habit. To assess the expected population health impacts of such a mandate, Tanks, Ahmad Moore and Gates 2004 created the tobacco policy model, which is a system dynamics computer simulation model that relies on simulating the population gradually. Although requiring cigarettes to be safer makes smoking more attractive and increases tobacco use, the positive side in such model is that the population can be healthier. Fraser and others in 2016 discussed how smoking bans have been implemented in a variety of settings, as well as being part of policy in many jurisdictions to protect the public and employees from the harmful effects of secondhand smoke. They offer the potential to influence social norms and the smoking behavior of the populations they affect. More countries lately have introduced national smoking legislation banning, especially indoor smoking and hopefully in many outdoor spaces. Nicotine replacement therapy replaces nicotine to avoid craving triggers, which can be tough to battle, especially when a person first quits. Nicotine replacement therapy has shown to be effective. Its products include Nicorette gum and the Nicoderm CQ patch, which gradually delivers nicotine to the body to help reduce cravings and symptoms so they don't get in the way of determination to quit smoking. The Nicorette lozenge, coated ice mint lozenge, is a new way to quit smoking. It is a convenient way to control cravings and it tastes amazing. The Nicorette gum is another effective method of nicotine replacement. It gives the mouth the relief of chewing and enjoying the option to use an extra piece of gum when experiencing strong or frequent cravings. The nicotine patch is used once a day. It is a low maintenance solution, flexible, clear, thin, discreet patch preferred by people who do not like to take oral medications. Among the medications used to suppress nicotine, we find the antidepressant bupropion, Zyban, and varenicline Chantix. The innovative nicotine agonists, varenicline, work by blocking the uniting of nicotine to neurotransmitter receptors in the brain, which stimulate smoking feelings, according to Breaker 2010. These pharmacotherapies are designed to weaken the foundation functions of smoking, which, in combination with behavioral interventions, would reach promising outcomes towards smoking cessation. So, once a person stops smoking, the body will overcome nicotine over time. And a person also has to break the social rituals and the habits established while smoking.